delay. Somehow the Mac didn't work. It was already working before. Now suddenly something has happened. So we're talking about decision making in the strabismus surgery. So the requisites for planning the surgery are the good refraction, proper glasses, best assessment of BCVA, and assessment of strabismus from the history, sensory status, and the motor status. Basic principles are basically weakening and the strengthening. Both of them are misnomers because actually neither we are weakening the muscle nor we are strengthening the muscle. What we do is actually just alter the length tension curve of the muscle. Now various recti procedures, weakening procedures are recession and Faden. Rest all are listed here. Commonly used strengthening procedures are resection, tuck, or plication. Now this table summarizes the maximum and minimum of almost all the recti, varying from 2.5 is the minimum for medial rectus and 9 which is maximum for the lateral rectus in recession and resections for the recti. Now few points worth considering whenever you plan a surgery. Bilateral recessions, they are preferred under GA because they either make similar or no changes in the palpable aperture. Also it is reversible as the tissue is not lost. Recession resection gives you a better, more effect per millimeter of muscle surgery, but one has to remember that not more than 2 recti in same sitting and not more than 3 recti in a lifetime can be done in any patient. Some other points like widening and narrowing of palpable aperture does occur even with the horizontal muscle surgery. Larger recessions can cause widening and larger resections can cause narrowing of palpable aperture. Ptosis can be seen with surgery of inferior rectus or superior rectus. Whenever we are planning a lateral rectus surgery, make sure that we separate it from the inferior oblique, as inferior oblique inclusion has been reported in approximately 1/3 of patients. For medial rectus surgeries, one has to be very, very careful as it is a small muscle. It can, if it is very tight, the muscle can be lost because of pitting. For inferior rectus surgery, it can have a direct and proportionate effect on the lower lid position. So limit the IR recessions to 5 millimeters and take care of ligament of Lockwood. For superior rectus, connections between the LPS and SR and superior oblique and SR should be taken care of. However, larger resections can be done in cases of DVDs. Now, surgical doses. Recession is a stronger surgery than a resection. Medial rectus is a stronger muscle than a lateral rectus. Large deviations tend to respond more as compared to smaller deviations. Younger children tend to have a greater response as compared to older ones. And then there are patient factors and surgeon's factors which can actually have a variation in your results. Now this is a patient who is having a 30 prism diopters with, without glasses and 15 prism diopters with glasses. So she's a case of partially accommodative esotropia, and we have to correct only the static component, that is the deviation with the glasses which is remaining. So this is the 9 gazes. There's nothing in the panning, in the secondary gazes and the tertiary gazes. So she's a case of clear-cut partially accommodative esotropia with no overactions of any other muscles. So what we plan is a right MR recession by 5 millimeters and we get this patient aligned. Another case of right divergent squint, we do a panning, secondary gazes and tertiary gazes. There's nothing else apart from the divergent squint. And what do we plan here is a recession resection procedure for a 45 prism diopter. What we are planning is 8.5 millimeters of lateral rectus and 6 millimeters of medial rectus. The question is how? The calculation goes like this. Whenever we are planning in my hands, LR 8.5 gives you around 2 millimeters, so it becomes 17. Medial rectus 3 millimeters will give you 18. So adding them together will make 35. And since we are doing RNR, so there will be 25% more effects, that is around 9. So we add 35 and 9, we get 44 prism diopters, and this is what we are aiming for. But we have to be very, very careful as there are surgeons and patients factors which can alter the results. And this is the patient post-surgery. Now this is a patient of consecutive esotropia with 30 prism diopters and diplopia. And we look back the old records. The old records mention that she's a case of basic intermittent divergent squint with 30 prism diopters of deviation. TNO was 120 seconds of arc, and there is no limitation of movements. She was planned for lateral rectus recession bilaterally by 7 millimeters. Now looking back the records, when we do bilateral 7 millimeters, we are doing 14 millimeters of LR, which should give 28 prism diopters of correction. But what we got was 28 of exo and 30 of ESO, which is approximately 60 prism diopters. So here, for a 30 prism diopters of esotropia, you would plan something like 4.5 to 5 millimeters of MR recessions bilateral if you're planning bilateral. Now, here, there is a stronger dose response curve. So what we do is just 1 MR by 5 millimeters. And this is what is the result. We can clearly see just by 1 MR, 30 prism diopters of esotropia is getting corrected. So now she's having a isophoria of 2 to 4 prism diopters, but such calculations can only happen when you are doing your own patients and you have the past track record. Now a few other considerations like distance near variation, pattern deviations like A and V phenomenons, oblique overactions, DVDs, head postures, limitation of movements, and paretic and restrictive strabismus, you have to plan your surgery accordingly. Now, if there is a variation in distance in near, we can plan LR resection or MR resection depending upon whether the distance deviation is more or the near deviation is more. For esotropia, recheck the glasses, bifocals can be given, and Farden can be added to a recession if it is required. For patterns deviations, sir has already discussed about the A and V phenomenon. We label A pattern when the difference is more than 10 prism diopters and a V when the difference is more than 15 prism diopters. We should always measure the deviation in up and down gaze to look for the patterns. And when you're planning for surgery in A and V patterns, if there are cyclovertical overactions, we should always plan for cyclovertical muscles. And if there is no inferior oblique or superior oblique overactions, we can downshift the MR towards the apex of V in case of V pattern and upshift the LR. Or it is easy to remember for MR that the MR has to be shifted to the apex of A or V. Now this is a patient of divergent squint where we can clearly see a V pattern. On secondary gazes, we can see a little bit of L over R in the dextro version and R over L in the levo version. And in the tertiary gazes, we can clearly see the inferior oblique overaction. So this has to be incorporated in your surgery whenever you're planning a squint surgery. Similarly, we have a pattern with superior oblique overactions. So this has to be considered when we are planning a surgery in these patients. Now, whenever we are planning inferior oblique surgery, whether we are planning at 8 millimeter recessions or a 10 millimeter recessions or an Ileton Nankins or a modified Ileton Nankin, all this depends upon the grade of inferior oblique overactions, what we are looking at. Now, this is another case where we have a divergent squint. Sorry, the animations are very slow because they were on the Mac and somehow the Windows is making them very slow. So here we can see a little bit of inferior oblique overaction like picture, but it is actually not inferior oblique overaction, it's a DVD with an exotropia. The inferior oblique overaction is apparent because there is a nasal bridge which dissociates the two muscles and the eye goes up. So this is the DVD of the same patient. I'm sorry, the video is not working on this. So what we plan here is, for a 14 prism diopters, I would plan a 7 millimeter LR recession. But since it's a DVD, we underdo for an exotropia and we overdo for an esotropia. So what we are planning is a right SR recession by 7 millimeters, left superior rectus recession by 10 millimeters, and LR recession by 5 millimeters. And this is 7-week post-surgery. We can see she's pretty well aligned. Again, the video which will not work. For paralytic strabismus, restrictive and special forms of strabismus, there are no fixed nomograms. Accurate measurement of deviation and sensitivity status is very important. Good assessment of eye movements is essential. Specific tests, if needed, should be done in all the patients, like force duction test or active force generation test. Choice of correct procedure has to be taken care before we are planning for surgery. And this is always required to have good results in strabismus surgery.